Ora si registrerà la conferenza.
Okay, here is the meeting, Siagascot, with one of the great maestri. I use an Italian word in the world, and great friend of us, great friend of Italy, great friend of Siagascot, a great surgeon, and I want to introduce to you David Dejour. Paolo, Ferrua, and me will interview David. 10 questions to him. We will discuss about the future, the present of knee surgery. And so I introduce Paolo Ferrua. Please, Paolo.
Thank you, Dr. Berruto. Thank you, Dr. Dejour, to be here with us today. And there are many good questions, very big questions, like philosophical ones sometimes. So maybe we can. Yes, we can start from Dr. Berruto. Maybe you want to start with the first question, which
Yes,
is.
I have to say first.
Yeah.
Grazie mille for this great invitation. I'm very proud and I'm very honored by this being interviewed by Massimo Berruto and Paolo Ferrua and by Siagascot. So I'm so happy about that. You cannot imagine.
I hope that you will be happy also at the end, because after this question, I don't know if we will stay again friends, but we try.
let's try.
So my first question is this: you represent one of the most important schools in the history of the modern knee surgery. So my first question is, in which area do you think that we have already reached the top on knee surgery, and in which area we need to improve?
Well, it's good to say that we cannot reach the Graal in any field. And I would say that we are always waiting to be better. And you see that each time you have new things, new fashion, new discussion, new debates in sports medicine, in patellofemoral joint, in total knee arthroplacies. So we always find some new things to discuss and to be better. So I don't think that we can say, well, we know everything about that pathology and it's over. Hopefully, it's never over. And hopefully, we always need to work together and find some new data to prove, to show, and to improve our practice and our patient practice, of course.
Thank you so much for this first question. So my second question is about something that is coming back. What do you think about the return of the quadriceps tendon as a graft in ACL reconstruction?
I would say that the return of the quadriceps tendon as a graft for ACL follows something that we call, and you know that very well in Milan, fashion. And fashion is always something new, and we rediscover always something that has been tested before. So we have seen that for the extra-articular-plasty, that everybody said that it was wrong, it was not necessary, and finally we found this new good anterolateral ligament, and fashion went back, and we discuss again about that. So quadriceps tendon is about the same. We use quadriceps tendon since a long time, mostly for revision, and some maybe the companies or maybe some people who try to find a topic to discuss is back on the field. Quadriceps tendon is definitely very interesting, but as all the graft, you always have some problems with. It's not the key. It's not the ultimate solution for an ACL growth, but it's interesting. So I'm happy to see the quadriceps tendon back on the field.
You almost burnt my third question. So now I was saying that anterolateral laxity has always been part of the French school, and Lyonese school in particular was something that was always taken into account in characterizing the instability and the type of laxity. So what were your sensations during the hype of the ALL reconstruction in the first time, and did it change your practice in the last few years, or you are still doing it in selected cases of revision and big instability?
No, but I have been very happy to see people speaking again about the extraarticuloroplasty, because I was taught by my mentor, father, and the Lyon school about the extraarticuloroplasty. And at the time when I was a resident or chef de clinique, it was the standard, the gold standard was to do a BTB plus extraarticuloroplasty, 100% of the ACL surgeries. And then we started to say maybe it's not necessary to use that in all cases. So we did a better selection in about, I would say, 40% or 50% of our patients. What is good with this ALL discussion, and that we are back with a big push from some people about ALL, is that we rediscuss it again, and then people start again to say, yes, it's good, and maybe we should do that now. And we had some new discussions. So we all had to think about, do some studies, prove, publish about that, the fact that an extraarticuloroplasty is interesting. What is wrong is to say that now, if you want to, if you don't want to have any re-rupture, do an ALL in every patient. This is wrong, and you have some selected indication. The menu à la carte, the same for ACL as for patellofemoral joint surgery, and this is what we are trying to do in Lyon. Trying to look at the slope, the static anterior tibial translation, just to set where you need to do it or where it's not necessary to add another procedure.
Okay, just another little question about that. Do you think that extraarticular-plasty like Lemaire, Christel, Cocker-Arnold are so different with the ILL reconstruction, which has been promoted more recently?
They are different in the way that when you do an extraarticuloroplasty like Lemaire or the other procedure that you discussed, it's a functional approach, because you go under LCL and it is definitely not anatomic, but it's functional, and it works very well in limiting the internal rotation. The other approach came from the cadaver lab dissections, where we found this anterolateral ligament, and the people who are doing an ALL use this anatomical approach, which is good too. Whatever the technique you use, the goal is to limit the internal rotation when it's necessary.
Perfect. Thank you.
Let's move to another topic, PCL. Why, in your opinion, and now PCL reconstruction, the results of PCL reconstruction are not as good as the ACL? Is a surgical, depends on surgical procedure, or depends on other problems? So, and where we need to improve in this area?
For PCL, I would say that our experience is not as big as for ACL because there's not so many PCL ruptures, and quite a lot of them do not need any surgery. So our technical skills are probably a little bit less. But I would say that why the PCL results are not as good as ACL is probably because we miss some associate lesion, especially for the posterolateral corner or the medial side also. And probably this is the reason why our results are not as good as for ACL. But if you screen well your PCL with a laximetry, with a good clinical exam, and if it's an isolated PCL, the results are really good and it works well too. The rehab protocol is a little bit different from ACL for sure, but the surgery works pretty well.
Thank you.
Now we will speak a little bit about patellofemoral instability that, if I remind well, it's a subject that you like a little bit. Now the question is a philosophical question. MPFL reconstruction changed a little bit the patello, changed a lot. It was like a revolution for the menu à la carte in the last 10 years. And does the MPFL change your indication on the other factors? So are you, in other terms, are you performing more MPFL reconstruction as an isolated procedure when all the other factors are mild? Did it change?
In my practice, I started to do MPFL I think in 2004. So MPFL was already on the podium before, and I moved from vastus medialis plasty, the insoleplasty, to MPFL. The insoleplasty definitely did nothing, and it was not really useful, but it was what we were doing in Lyon at that time. When MPFL was introduced, it definitely improved the subjective results in terms of stability because you have something which locks the patella on the lateral side. So it is very efficient in terms of to add this procedure to the other procedure. But on the other hand, it didn't change too much my indications because I follow the menu à la carte, and I follow the trochlea. How is the trochlea? How is the patella height? How is the TTTG? And I will add the MPFL to the other procedures. What maybe I do more in terms of isolated MPFL, it replaced probably the isolated medialization of the tibial tuberosity. So when at the time the only anatomical abnormalities was an excessive TTTG with a low-grade trochlear dysplasia, we were doing a medialization plus a VMOplasty. Now, definitely, I stopped doing the TTO, stopped doing the insoleplasty, of course, and I do an isolated MPFL. But I have to tell you that in my practice, it's not very often, and I do less than 10 isolated MPFL per year, and I do quite a lot of patellofemoral surgery.
Speaking about MPFL, do you think that the procedure, the technique that we are using now is a good technique, or as in other fields like ACL, we probably in the future change this technique, or you think that is a good technique and it's enough now?
MPFL to me is not the perfect technique, because we use gracilis or we use quadriceps tendon. Maybe the quadriceps tendon is more flat, is more like an anatomical MPFL. But when you use a gracilis, it's a tubular graft, so it's not exactly the anatomy. So this is not so perfect in terms of replacing the anatomy. But I would say that the technique is a technique. We could improve it. The most important thing is to say that a good MPFL is a loose MPFL. I mean that you shouldn't use it to realign your patella, your patella, and you shouldn't overtense it, because you will face some patellofemoral pain or stiffness. So this is where the indication has to be really clear and well defined, and the type of graft. I would dream to have a flat graft, a long graft. So you can maybe say, well, use the quadriceps tendon. The quadriceps tendon for me is sometimes a little bit too short, and that's why I'm not super fan of using the quadriceps tendon. So we still need to work on that. The thing is that less you put some hardware on the patella side, better it is. Using a screw on the femoral side is painful, so it's not perfect. So maybe going around the third adductor is not too bad too. So this is the different directions where we could improve the MPFL technique.
A last little question. Do you think that in the future we will, we have to find that this technique could generate some patellofemoral arthritis, like happens with Emslie-3i? When we begin to use the Emslie-3i, we overcorrect the position of the TTA, or you don't think so about that?
This is a very good question, and I like it because it allowed me to say that I will never use a synthetic graft for an MPFL, because when you use a synthetic graft, it's not elastic. Actually, maybe in the future it will be different, but it's not elastic. So if your isometry is not perfect, or if you overtense it, or if your position is not right, you will overload the patella on the medial side, and this could lead also to a patellofemoral arthritis on the medial side, exactly as when we were doing medialization of the tibial tuberosity without measuring the TTTG, so without using some objective data. So this is what is important: objective data. And what do you correct, and how do you correct it?
Thank you. Very, very interesting. We switch subject now, and we are going to speak about osteotomies. The last years have been described as the renaissance of osteotomies, because in some schools osteotomies were a little bit forgotten or defined as a niche surgery. But what do you think about the osteotomy now in your daily practice? Is it frequent for you to perform an osteotomy? When do you think the best indication is?
I love osteotomies, and I would say that the osteotomies, it is exactly what an orthopedic surgeon should know and should do, because you correct a deformity, and this is the orthopedic surgery is correcting deformities. So I'm very happy to see osteotomies back on the field and back on the first place. This is a little bit as we were talking at the beginning of this interview about the fashion. There is definitely a fashion about osteotomies, because we have new tools, new way to measuring the angles, some patient-specific instrument or whatever. But it's good because it shows that osteotomies is a good solution. So in my practice, I do some osteotomies. I'm for femoral tibial arthritis. I do opening wedge osteotomies, but I still do some closing wedge osteotomies, and I love them very much. And I think that the youngest surgeon should know how to do closing wedge osteotomies, and they shouldn't be scared by having a sciatic nerve palsy. It's just a technique, good technique. On the femoral side, of course, there are some indication to do some varus osteotomy on the femoral side because the abnormalities for valgus is mostly on the femoral side. So you should know all the different type of osteotomies that you have on your portfolio and use them. I will also speak about the sagittal plane, because in the sagittal plane you can correct the tibial slope, and in ACL revision, but maybe even in primary ACL, reducing the tibial slope is somewhere fundamental, and it works so well. So osteotomies in all fields are very, very important.
Thank you for that, for this message, David, because it's very important to have a menu a la carte also for the osteotomies and to perform all the type of osteotomies, closing wedge, opening wedge, depending from the patient and the need that you have to treat. This is very, very important, this message. I want to ask you about osteotomy. If you have changed in the last years your approach in terms of doing more double level osteotomies or things like that, or not, or you are still doing only osteotomy on one level?
I'm still doing one level osteotomy and doing a double osteotomy. Sure, it's the discussion is really open, and the orientation of your joint line is very important, and I love all the discussion about that. When the people when the surgeon say wow, it's so simple to do a double osteotomies, I don't really believe it, because it's tough to cut the femur and to cut the tibia, but it's somewhere possible, and sometimes it's necessary. But in my daily practice, I don't do it so much.
Okay, and you talk about the closing wedge osteotomy on the tibial side. I completely agree with you. What are your indication now in performing this kind of osteotomy?
My indication is when you have a big varus deformity, a big constitutional varus deformity with a pretty advanced arthritis. So I would say that the opening wedge osteotomies are really good when you want to do a small, a little correction. For example, when you associate that to an ACL, or when you have a very mild arthritis with a painful knee after medial meniscectomy. But when you have a big deformity, definitely the closing wedge osteotomy is for me is much better because it heals very fast. You can correct a big deformity, and this is maybe why the double level osteotomies are back on the discussion, because as some surgeon doesn't know to do a closing wedge osteotomies, and they cannot correct too much on the tibial side by doing an opening wedge osteotomies, they have to correct somewhere else. And probably this is the reason of double osteotomies.
Thank you. Now I move to a topic that you like so much, orthobiology.
I love that. I'm so fond of that. And I'm sure that I will give you some very good answers about that. But
So
I
do
hope
you?
that Elisabetta Cohn is not too far. And
I don't know.
I can count on you, Massimo, because you are the guy to speak about that.
No, my question is, do you think that really in the future, talking about the future, speaking about the future, orthobiology can become and represent finally a good solution, a reliable solution in the treatment of early osteoarthritis, or you think that there are no chance on this?
I would love to have that. I would love to have a 3D printing machine building again a new meniscus using cells that you have taken from your patient that you put in your lab, and then you have your 3D printing machine making you a beautiful meniscus. And maybe it might be the future, and this is definitely interesting. So of course I cannot do this type of work in my department or in our country. We are a little bit limited in terms of indication for that because of the reimbursement that we have for this type of surgery. So I'm looking very carefully to all the works which are being done, and listening to ICRS conclusion, listening to people who knows exactly how to use this autobiologic stuff. But for myself, I'm just an observer, and I don't have a big expertise in that. But I'm waiting for it. We are close to Christmas, so we know that maybe a gift could happen.
I'm happy to announce that we have finished the question on orthobiologics.
Thank you, Paolo.
We can go further and back to fashion. Back to fashion. In the last, I would say, 5-10 years, artificial intelligence and robotics came in knee surgery. What is the role for that in your practice? And as a second question, which is for you the future of these technologies in the operating room?
So I would say that the artificial intelligence is different from robotics. What I'm waiting for artificial intelligence is probably to have a better reading and interpretation in terms of the radiologic abnormalities, and I would be very happy to have some very precise diagnosis using our data, but allowing all the surgeons to have the best diagnosis in terms of for example, for patellofemoral joint, you put your DICOM images in a software, and it will tell you, oh, this is a high-grade trochlear dysplasia, or it's a low-grade, and maybe you should do that. So I would love to have that, and this is where I see the artificial intelligence. About robotics, it's a little bit more. It's a little bit different in the way that actually for total joint replacement surgery, it gives maybe a higher precision in what you are doing. So it may give a better confidence to young surgeons. What I'm afraid about is that the machine and the companies will take the lead in terms of surgery, and we will become technician, and I hate being a technician. I am not a technician. I am a surgeon who adapt my surgery to what I see during surgery. So what I love is to keep the lead on what I'm doing. If I use robotic and it works, perfect, no problem. But I don't want the companies or the rep or the engineer from one company telling me what to do. The good thing probably in that is that we will have, and the companies should have that right now, a huge data bank in terms of anatomical abnormalities, deformities, etc. And I'm sure that in the future we will be able to use all of these big data informations and probably improve the knowledge of what's going on in a joint.
Thank you very much. Very, very wise. We have two little questions from the audience. One is a classic of David Dejour's congresses. So it's like the role of the rotational osteotomies in patellofemoral instability. This is a classic. I heard that many times.
It's a classic, and it's always a good question, because definitely rotation abnormalities are important in patellofemoral pain and patellofemoral instability. The deal is always to correct what is the most important to correct. So if you have some low-grade local anatomical abnormalities on your trochlea, on the position of your tibial tubercle, on the patella, it's okay to look what is around, and what is around could be an excessive femoral torsion, for example, or maybe on the tibial side too, but mostly on the femoral side. And here, yes, it's good to correct it, and you have to correct it. Most of the time, I would say, personally, I find that I can correct locally the problem. But sometimes, yes, we have to do something mostly on the femoral side.
Okay. Thank you very much. Another question from the audience is about meniscus repair. So, what is your meniscal repair rate? Actually, do you have expanded it in the last years?
Yes.
Which is your approach to meniscal repair? This is the.
I have two. I have two approaches. The first is when I have a meniscus tear, isolated meniscus tear, no ACL, nothing around. You have a Bacatandle, and should we suture it? Should we fix it? And I would say that if you don't have a reason for this Bacatandle, your suture may lead to a failure. So if you're very young, under 20, I would say I will try the best, and I will try to suture it for sure. But after 20 years old, I'm not super fond of making a suture. In ACL, when it's combined to a ligament tear, I suture everything that I can suture, even if it's a very old person over 40 or 50 or 60 years old. I will make a suture. Why? Not because I think that it will heal, but it will improve my stability, and it will control the AP translation better. So it will protect the graft. And even if you have to remove the meniscus 3 or 4 or 10 years after, it's not a problem. I do the suture. What I have changed in my practice since few years is the root tears that I was not I was not really aware about that. I would say 10 years ago, and or maybe less. And now I do a lot of every time I see a root tear, even if it's incomplete or partial, I refix it. I refix it with a transosseous tunnel, because it controls also very well the rotation when it's combined to an ACL. So this is definitely something that I do very often, and I try to suture almost everything when it's combined to an ACL.
You have speak about the root tears. You say that you fix the root tears probably on the lateral meniscus associated with ACL reconstruction. My question is on the other side. You know, early osteoarthritic knee, root tears of the medial meniscus, and meniscus extrusion. Do you think that in the future we will fix this lesion acutely, just to reduce the evolution of the knee to osteoarthritis, or you don't think that this will be an evolution of our surgery?
Well, as I told you, I'm not super fond of fixing a meniscus which is somewhere isolated. And if you have an extrusion of your medial, I'm speaking mostly about the medial meniscus. If you have an extrusion of your medial meniscus, it means that there is a reason for. What is the reason for is probably the cartilage thickness, which start to be thinner. So it's early arthritis. If you have a root tear on the medial side, it's very tough to repair it, and I'm not so sure that you can reintegrate the meniscus in the joint. Actually, you have a trend which says you fix the root and then you put some anchors on all around the meniscus on the bone, just to reintegrate the meniscus in the joint. I have seen that when I did the ESCA AOSSM traveling fellowship in US, and some surgeons were starting to do that. It's come from, I think, Korea. In Korea, they are doing that quite a lot. Very tough surgery. And frankly, I don't believe in it. And I am more mechanical, and I would definitely move more to an osteotomy solution than a soft tissue solution.
Thank you. So we can move to another topic, the total knee replacement or treatment of arthritis in the future. I think that my opinion is that the total knee replacement now are quite good, but not so good. And so I want to ask you if in the future, what do you see the future in the treatment of arthritis? More uni, more mini implants, more custom-made prosthesis. What is the future of the prosthetic surgery for the knee in the future, in your opinion?
But Massimo, the future is orthobiologic. So you don't need any total joint replacement now.
I don't think
now
so.
The future for total knee arthroplasty, it's tough to answer, because when you look the literature in terms of total knee arthroplasties, sometimes it's a little bit depressing, because if you resurface the patella or not, no changes, no real advantage to do one or the other. If you look at the computer-assisted surgery versus mechanical surgery, no differences. PSI, no differences. Robotic, not really big differences, actually. Probably we'll see in the future, but it seems that it's not so different. Custom-made total knee arthroplasty versus on the shelf. A recent study showed that there is no really big differences. So it's always very tough in the degenerative field to know exactly what is good, what is wrong, because you need to have long-term studies, and in long-term studies, well, it takes time. So what is definitely important for me is how you position your total knee arthroplasty or your uni, the indication not to do surgery too early, and probably the painful total knee arthroplasty, maybe it's because the surgeon pushed a little bit too fast the indication and didn't wait the patient to be really painful. So the patient are not very happy with this total knee arthroplasty. And how could you know that? In the studies, we don't really know. We just have actually the people say that we have 20% of low results in total knee arthroplasties. But what was the indication before? Is the patient was really painful? Is the patient needed really a total knee arthroplasty? I'm not so sure about that. So this is a question mark for me. Definitely the design of the total knee arthroplasties are important. We have seen that for the patellofemoral joint, for example, we have seen that some total knee components were dysplastic, so we could improve that. So we need to push the companies still to work on the design of a total knee arthroplasty, and not only about the way to position it with a robotic. Probably the balancing, how to balance your total knee is very important. And the custom made is okay, but sometimes is that really necessary? I'm not so sure. I cannot say yes or no, but I am not super fan of fancy solution. I am simple, humble, and I would say that most of the time you can manage it with this. About the unis, uni is definitely a very good solution in specific indications, and when you use it in specific indication, yes, it works so well, and this is really anatomic. And here you keep the mechanical axis, you keep the kinematic alignment or the revert kinematic alignment or whatever, because you have no choice. You have to put this uni in the ligaments balance. So that's good.
Great.
Just a quick comment about that. So, what do you think about staining the soft tissue envelope of your deformity in a total knee implant? So the so-called personalized alignment. Do you change your alignment with your different deformities?
Definitely, it's good to bring back the leg a little bit straight, and the patient are so happy when they have a 10 degrees deformity and they are back to a pretty straight leg, and they say, oh, the doctor, you really did something to me, and they are happy about that. Keeping a little bit of deformity is probably good, and this is somewhere what we are doing even without the robotic and before the personalized approach of a total knee arthroplasty, because when you use the mechanical tools, you put 7 degrees of valgus on the femoral side, and so you probably undercorrect a little bit and you keep a little bit of valgus. The same for the valgus deformity. So what we have with the robotic or the better planning, because the robotic push you to have a better planning, is definitely interesting. It is dangerous to give the message to young surgeons to keep the deformity, the constitutional deformity, because the constraint and the interface between your total knee arthroplasty and the bone is definitely much better if you have a 90 degrees compression than if you have a 3 or 5 degrees various deformity. So I would say that it's very good if you are very skilled and if you have a good experience. The message for the young surgeon is be classic a little bit, make your experience, and then move a little bit to a more a better fine tuning of your surgical planning.
You almost started what I was asking you now. So to give a final comment with a specific destination to our young surgeons and residents, what are your pieces of advice? What are your conseils for these young?
My advices are definitely to when you train, you belong to an orthopedic department. You have a mentor, and your mentor tells you you have to do that, and never forget what I'm doing is good, and you have to follow that because you will follow somebody who knows, and you will learn how to do surgery. You will improve your skills, and definitely you build what you will be in the future. And then when you have this basement, this basic knowledge, you are allowed to go and visit some other surgeons, to see a different organization, to see a different thinking, to see a different way to treat one pathology, because you never have only one solution for one problem. And it's very good to travel and to go abroad, to go to another country, and you know that Paolo, it opens your mind, it changes your life, in fact. So I will push everybody to spend at least 6 months in another country, in another philosophy, in another culture, because it makes you much more intelligent. What I would say to the young surgeons is to be very careful about fashion and what it is pushed by companies or surgeons who do a lot of advertising for each devices, because it could be dangerous. And this is why I feel the scientific societies like CIAGASCOT, like ESCA, like our Francophone Arthroscopy Society is important, because we deliver unbiased information, unbiased studies, and so it is a balance to what could be a little bit biased information given by some other canal. So this is the best message that I could give to a young surgeon.
Great message, David. Very. In Italy we say saints' words, so parole sante, and that's this is a conclusion, the end of this meeting with you, and we want to thank you so much, because you gave us a lot of things to to think about, a lot of messages, and you demonstrate again that you are a great surgeon, a great friend, and really a mentor for everybody of us. Mm-hmm. So I want to thank you again.
Grazie mille.
Paolo, if you, I don't ask you to sing, because I don't ask you to sing, and I give the conclusion to Paolo.
Thank you very much. It was very interesting, and it's not so easy to be questioned by Dr. Berruto. I know that in my personal practice. So it's more about orthobiologics. but you gave us a lot of things to discuss and to rethink about. It was very interesting, and I wish to thank you personally and in the name of Siagasco to be here with us tonight. And thank you, and see you soon.
Massimo, Paolo, Siagasco, thank you so much. Grazie mille. You know that I love Italy. I love your society, and you are doing so great job. You are so innovative, and even Massimo, who asked people to sing some songs. It's somewhere crazy, but the message is also to be a little bit crazy. Sometimes it makes you much better.
Thank you so much, and we wait you in Bari to our meeting, next annual meeting in March, and so we will wait for you again with Siagasco friends. You are a great friend of us, so thanks again for your time and to be our friend.
Grazie mille. Arrivederci. Arrivederci.
Ciao.
Ciao.